So with these few words, we'll move to the first talk, which is by myself, technology for multifocals, what is essential, what is not.
Dr. Anup Chirayath does not need any introduction to the audience, but for formality's sake, he's a prolific anterior segment surgeon, very well experienced in all sorts of IOL technologies, and he's the director of Eye Vision Eye Hospital, Thrissur. Over to you, Dr. Anup.
Thank you, Dr. Soni. So it has been written somewhere that it is in the literature that it is nearly impossible to create a lens which gives a perfect image at varying distances with no aberration and with no loss of light. What it essentially means that it is not possible to give God-given sight like to a person, to a human being who is emmetrope in the pre-presbyopic age. But yes, multifocal IOLs are a technology and evolution because the lenses that we used 10 years back and the lenses which are available now, there is a dramatic difference between the two, between the results. As all those who would have used the earlier generation of multifocals and the present one will definitely vouch for it. Now the patients are much more happier, but it is still technology and evolution. So as would have been said thousands of times that what is most important is the proper patient selection. And which should be based, patient selection, which should be based on the lifestyle of the patient, that is the hobbies and what are the things that the patient likes to do, the personality of the patient and the needs of the patient. So ultimately one should always choose a patient who is motivated. That is somebody who doesn't want to use glasses is always the best patient because they are unlikely to complain post-operatively. And those who are pre-operative hyperopes, that is, they are the patients who have neither distant nor near vision clear. So they are the people who will be definitely happy. And definitely avoid the hypercritical or demanding patients, occupational night drivers, and those who have undergone a previous refractive surgery. There is an irony in that because these are the patients who are motivated because that is why they underwent refractive surgery in the first place. But unfortunately, in these patients, we cannot guarantee emmetropia after surgery. And low to moderate myopes also, they are used to such clear near vision without glasses that none of the present generation IOLs can guarantee that sort of near vision. So what is the technology we are talking about? There is nothing great in the technology. One is the patient questionnaire. That is, these questionnaires the company people themselves give us and which we have to modify it based on our the patients in our own locality and the culture of our own patients. An ultrasound biometer with immersion is more than enough because we have been we used to do immersion biometry as well as we also have optical. So just to cross verify the two so that we can pick up if one machine is not working well, at least the other one, if there is a difference, then we again recheck. So while doing that study in a hospital, we found hardly any difference in the axial length measurement between ultrasound with biometer and optical biometer. A good slit lamp is important because I think that is something which is really important. If you want to invest somewhere, please invest in a good slit lamp because any small amount of donuses like small subluxations, iridodonuses, phacodonuses or small subtle opacities near the pupillary area, those things can be picked up only with a good slit lamp. And always we have to use newer formula. We have those available online because they are the ones which will give you more, will guarantee you emmetropia post-op. And a good microscope and phaco machine, which anyway as a phaco surgeon you will definitely be having. Some things are an luxury, but they may not be essential, like an optical biometer, which is gradually, probably over a period of time, it will become essential because since everybody will be having it. But still it is not essential. Toric assisting devices like, for example, if you are planning toric multifocals, then like the Varion or Callisto, they are also not essential. And I wish the eye trace tonometer for measuring angle kappa and angle alpha, which is, they say there is importance, I will be speaking about that. And the ORA, which is the new kid on the block, which is something like a biome which we attach to the microscope. So that is, which gives a real-time biometry. That is, after you have removed the cataract, in the aphakic state, you will get the biometry. So what the advantage they say is that already the sections have been made and the effect of the sections on the cornea has already been there. So after that you are measuring the biometry is more likely to be more accurate, but also definitely extremely costly. So coming to angle alpha and angle kappa. Angle alpha, as you know, is the difference between the center of the limbus and the visual axis. That is from limbus to limbus, the center of that. So what we effectively mean is the center of the capsular bag or the center of the implanted IOL. So between that and the visual axis, that is the light passing through the object of interest to the fovea. Angle kappa, on the other hand, is the difference between the center of the pupil and the visual axis. So if you see the first image on the upper part, so there all these three dots are almost in the almost overlapping or near to each other. So this is the ideal situation. And in the lower image, you find those three dots are separated. And in that, if you see, the yellow one is the visual axis and the green one is the optical center. So there is a big difference in the gap between the two. So what it means is that those rings of the multifocal lens will not be uniformly exposed in the pupil. So it will be like the central ring would be slightly ectopic. So that is not what is desirable. So at the same time, there is no absolute consensus on the range of angle kappa and angle alpha. Generally, it is said that if it is more than 0.5 millimeter, that is horizontally measured on the cornea, if it is more than 0.5 millimeter, the angle kappa and the angle alpha, then the patient may not get optimal vision. But it can be measured only with the eye trace aberrometer. You can even measure, they say, with a autorefractometer, but I have not tried that. Tips for success, again repeating the same thing, proper patient selection, accurate biometry, always aim for emmetropia or slight hyperopia, never try aim for myopia. Use newer formulas, good surgical technique, because if your phaco is good, you should attempt for a multifocal. All steps are crucial. Proper lens selection based on the patient's personality type. And ultimately, the patient should be clear about their priorities. A confused patient is not a right patient. The patient should know what I like and what I don't like. Sometimes all patients are not very clear about what they want. And the surgeon should be clear about the options, about all the lenses which are available, the pluses and minuses of each lens. And the marketing people, they will never tell you about the minus things. They will say that institute they are using, this institute they are using, and they are having excellent results. But you have to go through the details about the pluses and minuses of those lenses. You have to talk to your friends who are using it, so they will give you proper guidance. So operating on these lenses, like I said, all surgical steps are important. The sections should be good, and most importantly, the rexes. It should be round, it should be well centered, and it should be circular, around 5 to 5.5 millimeter. And after implanting the lens, I always implant under BSS. So the lesser the visco, better, because once you removing all the visco is a neck. And at the end of the procedure, this is important. You have to tinker around with the lens with irrigation so that the lens is well centered and all those Purkinje images should be there in the central zone. The first and fourth, I will just show you again. And this is a toric multifocal. So again, I always still mark all my torics on the slit lamp with a beam of the slit lamp. And I have hardly never got any patient who was unhappy. I was complained that my axis is decentered. I am not saying that all my lenses are on the dot, toric, but a slit lamp gives excellent result. And here again, after inserting the lens, you have to spend some time. You have to, like you're tinkering around with the lens, so to see that you just you shake it around and see that it is well centered. And always I always try to mark the axis, even if the axis is less than 1 diopter. Always mark the axis so that you can keep your incision can be made on the steep meridian. So even the 0.5 diopter of astigmatism can be reduced by at least 0.3 millimeters. So after that, this is the coaxial light. If your microscope has oblique as well as coaxial, you switch off the coaxial and only with the switch off the oblique, and only with the coaxial you ask the patient to look at the light, so that that is the visual axis. And your fourth and your first and fourth Purkinje image should fall within that central area. This is marking the steep axis. This is not a toric. And then making the section on the steep axis. You can see those Purkinje images. All of them are in the central zone. This is a EDOF lens, the non-diffractive type, the VVT. And at the same time, I also feel proud to say that a lot of our Indian companies also are making excellent all the trifocals as well as EDOF lenses. So this is an Indian make of a trifocal lens. And they also have excellent results. It's not necessary that you have to use only the extremely costly the multinational lenses. Even the Indian make ones give good results. So those are the Purkinje images. So aligning the first and fourth with the coaxial light of the microscope. The reflection should be in the innermost ring. Unhappy patients, those with lens decentrations or tilt, which may occur if your axis is not centered. Those with inadequate pupil size, that is, some people, they after surgery the pupil shrinks a lot, comes to almost a very 1 to 2 millimeters. So in that you don't get the benefit of the multifocal. Residual refractive error, posterior capsular opacification, which can be easily managed. Patients with photopsias and those with dry eyes. And though you may have advised multifocal, you should always be willing for a change of plan, because if there is a large PCR, you have to place the IOL in the sulcus. If there is a zonulodialysis, a CCC tear or a pupil trauma, then you may have to shift to another lens. Because in these situations, the lens, your multifocal may not be centered well. So optimizing results, binocular summation, what it means is that you have to implant the same lens in both eyes and with not too much of a gap. And neuroadaptation, which is a lifesaver for many of us, which basically means the patient adjusts by himself over a period of time. So a patient after 3 months may not really complain as much as the patient complains the next day. So never try to do anything interventions immediately after surgery. You tell the patient everything will be okay, and come again after 3 months. 90% of patients they won't come back. Mix and match again is also possible. The newer modalities, that is the enhanced monofocal with micro mono vision. The low add EDOF in one eye, dominant eye, and the higher add EDOF in the non-dominant. EDOF in the dominant eye, and trifocal or multifocal in the non-dominant. In special situations, young patients, EDOFs are better because you don't know in future what their maculas would be like. And diseased eyes like corneal opacities, glaucoma, macular pathologies, always best is monofocals, or if at all, you can go for a non-diffractive EDOF. Newer lenses, like I said, technology and evolution, newer lenses are keeping on coming in the market. The one with the black ring is the IC8 Aphthera by Bausch & Lomb. So it's a monofocal lens with enhanced depth. A clear view lens by LensTech, so that instead of diffractive rings, it has got segments. So all the advantages are diffractive, but the glare and halos are less, is what they claim. And the third one is a very the light adjustable lens. It's like futuristic, but it is available, where after implanting the lens, post-operatively you can modify the power of the lens by exposing the eyes to UV light. So you can change the power of the lens. So that is available, FDA approved and available in the US. I don't think it has come to the Indian market. But that is something gratifying, but still a long way to go. Yeah. Thank you.
Thank you, Dr. Anup, for that exhaustive overview on multifocals and EDOF technologies. Can I ask you one question? Yeah. There is a definite overlap between the enhanced depth of focus and the so-called EDOFs. So, when you talk about using it in young patients or diseased eyes, would you go for an enhanced depth of vision or the X-EDOF or the modified EDOFs?
I would always prefer the enhanced monofocals, because whatever said and done, already their contrast sensitivity and their is already would have been reduced because of macular pathology, maybe macular edema, whatever the reason, or the corneal opacity also. So monofocals or enhanced monofocals. They say that they do give non-diffractive EDOFs also in those patients who demand it, but I personally would prefer enhanced monofocal. Yeah, thank you.
Thank you.